Good day, ladies and gentlemen, and welcome to the Medical Homes and Care Transformation Web Conference. At this time, all participants are in the listen-only mode. Later, we will conduct a question-and-answer session, and instructions will be given at that time. If you should require assistance during the call, please press star then 0 on your touch-tone telephone. As a reminder, this conference is being recorded. I would now like to turn the conference over to your host, Mr. Fred Guilefus. Sir, please go ahead.
Thank you very much. Hello, I'm Fred Guilefus, a partner with Foley and Lardner, and I'd like to welcome you to today's webinar, The Role of Medical Homes and Care Transformation. Foley and Lardner is very excited to present this webinar. It is the second session of a series of webinars we are doing on care transformation. That is our title for the numerous activities that are occurring in the healthcare industry, both with private participants and through a number of government initiatives. They foreshadow how healthcare payment and delivery is changing, and we think will continue to change in the coming years. Today our focus is on the primary care medical home, and we have an outstanding panel of speakers. I took a run through their slides, and I have found them very worthwhile, and I'm sure you'll enjoy them. Our speakers today, after a brief introduction that I'll do, are Marcy Nielsen, Mina Harkins, Dr. Leonard Fromer, Dr. John Sprandio, and Marcia Guida James. But before we start, I'd like to go over a few housekeeping tips. Today's program will run approximately 2.5 hours. Live questions will be taken at the end of the program, and questions can also be asked during the program by clicking on the Q&A tab on your screen and typing in your question. Your feedback is greatly appreciated, so we ask that you take a few minutes and complete the survey that will appear on your screen after the Q&A session. We will apply for 2.5 general continuing legal education credits for today's program. New York attendees have special rules, and those applying who are New York attendees and members of the New York Bar applying for CLE credit must fill out an attorney affirmation form and write down the 2 course codes that will be given during the course of today's web conference. A form can be obtained by contacting the email address reflected there, zrahim@foley.com. But now let's get on to our program. As we will hear from our speakers today, the economics of healthcare are requiring a new approach. Our current system is not what anybody would design from scratch, and most are saying it's not a sustainable model. Participants in healthcare are recognizing the compelling need for change in this care delivery system. And I think, I've been practicing healthcare for a number of years, and it's almost healthcare 101, that to have effective change in how you deliver care, you have to change how you reimburse it and pay for it. It's critical to any successful care transformation. But I think the care transformation is a question of whether, is not a question of whether, but a question of when it will happen, and also how do we get from where we are to where we should be. I'm also of the view, and I know this is shared by many, that the result of Obamacare in the Supreme Court and the 2012 presidential election really don't matter very much for the care transformation that's taking place. It will happen regardless of what occurs at that level. The care transformation we're seeing is moving away from volume-based fee-for-service payments to a system paying for value and outcomes, and a system, frankly, that just does not reward more services. The key goals are to restrain the cost increases and achieve better quality for both populations and individuals. But what form will this care transformation take? Today we are in numerous conversations. There are demonstration programs. We are testing a variety of various forms. We're seeing increased collaborations between hospitals and hospitals, payers and providers, and all variations thereof. We have providers taking risks. We have payers getting into the provider business. And the question is, how do we get from where we are to where we need to be? And a real question I ask of myself frequently is, what's care going to look like, and what's our delivery system going to look like in 7 to 10 years? And as I do that, I think that medical homes will be a critical component of what the future holds. Today, there's been significant medical home activity, a lot of demonstration programs and discussions, and we'll hear a lot about those from our speakers today. And initially, the results are very positive. Our speakers will report on some of the programs that have been tried and some of the initial successes. At the same time, I think you have to ask yourself, what are the opportunities and challenges for medical homes to become successful and prevalent? And our speakers will talk some about those issues as well. First of all, I think it's important as an introductory concept to understand what a medical home is, a patient-centered medical home is. It was first introduced by the American Academy of Pediatrics in 1967, but the concept has changed since then. Here is a definition that I have seen of a medical home, and I think it captures a lot of it. It's not a building, it's not a home, it's not a hospital, it's not home health care. It's an approach to providing comprehensive primary care with the goal to proactively manage a population of patients with better access and quality. Several of the key components are that it's primary care, physician-led team, extensive use of care managers and mid-level providers on the team. There's an ability for the team to get up-to-date and current data. They share with an electronic medical record and quality reporting systems. There's open scheduling and expanded hours, and preventative services and management of chronic care are critical components. There have been announced some joint principles and attributes of a successful medical home, and some of those are listed here. A personal physician, a coordinated team of professionals, the whole person orientation, quality and safety are at the forefront. There's enhanced access, and there's pay reflective of the value that's being provided. Here is a chart actually put together by Health Affairs, where it shows some initial examples and results of some pilot programs. And you'll see way over in the right-hand column, the dollar savings per patient have been significant. The reduction in hospitalizations have also been significant, and the ER visit reductions have been significant. These are medical homes that are being tried are working, and I think the future suggests that medical homes will be an important ingredient of what we see in healthcare. Here's some reflections on some quality that data was collected by Harris Interactive and reported through the Commonwealth Fund. And again, it shows the presence of a medical home makes it easier for obtaining care outside of the ER, availability of records, reductions in lab errors, doctors given for managing care at home, and receiving reminders of preventative care. So on a number of factors that have been measured, medical homes are providing significant improvements in care delivery. And our speakers will dive into that much more as we move forward. Finally, I think, again, as I indicated earlier, it is critical to understand how payment works when we go into medical homes. And here are some of the examples of payment structures that have been tried. One of the key challenges to widespread prevalence of medical homes is to get the payers to start using payment methods and utilize them broadly. And it's not just the payers. The providers also have to embrace it and work with the payers to make them work. But we've seen, typically you'll often see monthly care coordination payments, plus a fee-for-service payments and performance-based incentive payments. Some have tried just enhanced fee-for-service E&M payments. There's been discussion of creating new CPT codes for medical home activities. Some of the models have tested per patient per month medical home payment, which is in addition to the E&M fee for service payment. And again, there's also, we've seen some risk-adjusted per member per month payments for primary care services. So we are seeing a variety of different payment structures, and I don't think that anybody's coalesced around one model that works best, but we're trying a variety of different structures, and we'll hear about those as we move forward. But what I would like to do now is to introduce to you Marcy Nielsen, who will be our first speaker. Marcy is the Executive Director of the Patient-Centered Primary Care Collaborative, a large coalition of providers, clinicians, purchasers, payers, and consumer stakeholders who have joined together to advance an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home model. She previously served as the Vice Chancellor of Public Affairs and Associate Professor with the Department of Health Policy and Management at the University of Kansas School of Medicine. Marcy has both state and federal healthcare experience, and prior to being at KU's faculty, she was the first executive director and board chair appointed by then-Governor Kathleen Sebelius to oversee Kansas's healthcare agency and the Kansas Health Policy Authority. So we're very delighted that Marcy is here, and she's been working with medical homes now for quite a while, and really looking forward to her comments. Marcy?
Thanks a lot, Fred. I am going to jump right in and hopefully add to much of what you've heard a fantastic agenda setting by Fred. I'm going to add to that by hopefully taking a step backward for a minute and looking at this concept of a patient-centered medical home broadly, because I think we hear a lot about the term in health policy circles, and we have made great inroads, as Fred has pointed out, in getting healthcare providers and policymakers at both the federal and state level, as well as numerous commercial health plans to support this concept. But patients and families, or consumers, if you prefer that term, are still largely unaware of what a patient-centered medical home is. I appreciate Fred pointing out it's not a nursing home and it's not a building, but those consumers still don't really know what it is and why it's important. I thought I would use a little bit of time today to explaining the PCMH, much like a reporter might, looking at the 5 W's, the who, what, when, where, and why, before we really dig into some of the terrific presentations that will be following me. I'm doing this not only to help you all try to level set or increase your understanding of the PCMH and its history, but also as you work with your clients, that you feel like you can educate them because we have a little ways to go on that front. So let's start with the why. Why patient-centered medical homes? As a pretty sophisticated audience, I'm guessing you're already well aware of the multiple issues within the United States healthcare system that have led us to really embrace this model of care. But again, think it might be useful as you work with clients to be able to better understand them yourself. It doesn't take long in a conversation about the U.S. health system to quickly come to this topic of health costs. As many of you are well aware, we pay more than any other industrialized country in the world for health care, but you may not be aware of all of the reasons why that is the case. And I think this chart does a terrific job of reminding us, relative to other countries, that in the United States we have both public and private sectors paying nearly an equal amount of money for health care. And then a sizable chunk is paid on top of that for health care out of pocket by individuals. The reason why this is important is because we can't really address all of the solutions to these problems in isolation. We need to have both the public and the private sector working together to address the fragmentation in our system, and I'm going to say a little bit more about that in a minute. This is obviously relevant as we look to Congress and the gridlock that we now see around many of these issues. I mentioned public-private sector spending a lot of money on health care. The government is terrified when they look into the future and see charts like this. Of course, this comes from the Congressional Budget Office, the only official scorekeeper of health care spending. And this tells us that our long-term deficit problems are nearly entirely derived from unsustainable growth in health care. And this chart shows you it's really the dark blue, Medicare, Medicaid, the Children's Health Insurance Program, and the exchange subsidies that basically will eat up our budget as we move out into the future. You'll notice that Social Security spending is largely flat. So it is indeed health care that is going to be increasingly important in controlling health care costs. This particular chart, the cost of healthcare waste. I mentioned we have public and private sector spending almost an equal amount. This leads to lots of fragmentation and inefficiencies. This particular chart points directly to those inefficiencies. I would suggest that most economists suggest that 30% of the annual $2.5 trillion that we spend is waste. A full 30%, which is the equivalent of $700 billion a year. When you then look then at opportunities for investments, so ways to shift us away from that $700 billion in waste, you can see that despite the fact that we're spending that amount of money, much of that on important care, but much of it on care, as the previous slide points to, being inefficiencies, care that is unwarranted. You see the United States really being an outlier when you contrast what we spend with life expectancy in years. So important to recognize that despite the fact that we're spending much more than other industrialized countries, we are not getting the value needed. Which points us then back to some of the solutions, and primary care being at the top of that list. I just pointed you to some of the problems. You've heard Fred mention some of the experiments that are underway. We'll be hearing more about that in today's webinar. There are a number of opportunities at both the federal and state level, but importantly in the commercial world, in the private sector, by health plans and employers to really advance a number of ideas, most of them founded on a primary care patient-centered medical home. And we've got years and years of studying primary care, understanding what works, to help point us in the right direction. And this slide mentions the 300-plus studies that have looked to primary care to better understand what's working. So what is the what? And this takes us back to the patient-centered medical home and some of the things that Fred described earlier. But I want to dig into the features of a patient-centered medical home and spend a little bit of time on this slide, because I think there's still a fair amount of talk, at least in this town, about payment reform and ways that we support patient-centered medical homes without really understanding exactly what it is we're talking about. So I'm going to start with this concept of comprehensive team-based care using the Agency for Healthcare Research and Quality as a means to describe each of these boxes. So comprehensive team-based care is fairly obvious, using a team of providers working closely together to provide care to patients. This team certainly includes physicians, but it includes advanced practice nurses and physician's assistants. It includes pharmacists, nutritionists, social workers, care coordinators, using a large and diverse team to focus back on the patient and their families and what their needs are. this links us to the next box, to the right here, that patient-centered orientation. And I can't stress enough how critical this is going to be in the months and years moving forward. Most patients today don't understand what it means, the term itself, a patient-centered medical home. They do know what it means to be in one. They know that their care is better, that it's better coordinated. They understand that they're receiving better access to services and that they're working very closely with the providers in a given practice to meet their needs. We need to remember as we're working around this patient and supporting their preferences and their needs, that we're focused on their culture, their value, their preferences, their health literacy, and that we have the cultural competence to be able to offer a patient-centered orientation through a PCMH. The next box takes you to care that is coordinated. We see so much evidence in this particular aspect of the model. It's very difficult for patients and their families, particularly when they have a number of different health conditions, to navigate the very complicated health system that we have. And so helping those patients and their families coordinate that care, moving back and forth between perhaps a hospital, nursing home, back to being out in the community, a key function of coordinated care. And then having superb access to care. Those physician practices that offer patient-centered medical homes really try to have 24/7 access to their patients, whether that's through email, through telephonic support, whether patients have access to patient health records, having access for patients in an asynchronous way, meaning patients can get information from their providers, whether that provider office is actually open or not, is an important way to provide access to care that is increasingly important to patients and certainly to younger patients. And then finally, having a systems-based approach to care. Fred mentioned the importance of population health. We've got to be using evidence-based clinical guidelines that support health for a whole population of individuals, not just the patients themselves, but whole communities. And how do we do that? We need to have metrics in place. We need to measure the kinds of care and outcomes that we're tracking. We need to be asking patients what their experience is and making sure that they're satisfied with the care that they're receiving. And so having a strong health information management backdrop that connects all of these components of a patient-centered medical home, and then paying providers and whole teams of individuals, whole teams of providers is going to be important as we move forward. We are still very much on that trajectory today. This is another pictorial way to take a look at a patient-centered medical home. I've mentioned many of these concepts. Fred mentioned others. I would just want to stop here for a minute and point out that we are going to need to refocus the way in which we train our providers today. And I think we've just started down that road, and I hope we hear a little bit more about that from Len Frommer. You'll be hearing from him in a bit. We don't yet train providers to work together in our academic medical centers, although there are places where we're beginning to do that. But we need to change certainly how we're providing that education. The next slide really points out the importance of this trajectory for how we not only buy healthcare services as employers and as health plans, but also how we pay for those services, and making sure that as we utilize health information technology and we think about the capacity within a patient-centered medical home, that these concepts lead us to a world in which U.S. healthcare reports back to the population on the quality, the utilization, patient satisfaction measurements that demonstrate that these models in an accountable care world really can be effective in the long term. And I'm going to circle back for a minute to how much we're paying for healthcare in this country. Unless we can demonstrate that we can both improve health outcomes and save money, and that is no easy feat. We're going to miss this tremendous opportunity that has presented itself through the Affordable Care Act, through the leadership that we see at the state level, and in those commercial plans and by those employers who have embraced this model. It is a paradigm shift, and paradigm shifts take some time, but they also take some change in thinking. So I don't intend to read to you this slide, but just recognize a number of different ways we need to think differently, moving from a world in which we're treating sickness to we're managing health of the population. We're looking at fragmentation of care toward collaborative care. We move away from care that is solely focused on specialties, and we use the primary care system that is particularly well suited to coordinate care and work with patients in a longitudinal relationship over time, utilizing information, utilizing the evidence that we see in the research world, moving away from paying for volume, paying for value, moving away from this fee-for-service system. You hear a lot about accountable care organizations and how this might comport with patient-centered medical homes, and I just suggest that the two are well suited to work together. And this slide that I got from the chair of our board, David Nace at McKesson, I think does a very nice job of tying together these concepts. You'll see really an accountable care system uses patient-centered medical homes to coordinate care using care coordination together with our partners at the hospital in the specialty care world, in public health. They're all necessary toward achieving accountable care. And when is this going to happen? When should it start happening? This is a very busy slide meant to suggest, as Fred pointed out, that it's been happening really since 1967 when the American Academy of Pediatrics began this model. But there are lots of folks who have weighed in on how we do this better, and you'll see several pictures of the folks who have been working in this regard. I'm going to point you back to the patient-centered primary care collaborative here in a minute, but would want to call out the role that the Institute of Medicine and the leadership they've provided has played, and I'm going to land you back on where we find ourselves today, which is the Affordable Care Act being passed in 2010. We're in a bit of a standstill as we look to the June Supreme Court decision Fred has alluded to, certainly the November election being an important component of the trajectory that this country takes next around these important ideas. Shifting to accountable care, as I mentioned, being such an opportunity in this country, important to recognize some people are waiting and watching. Others are just putting a toe in, while many people have been diving in head first, taking laps and taking the deep plunge, and I'm going to tell you a little bit about some of those folks and where they are. I'm not going to read any of these slides to you, would hope that you have a chance to look back at some of the details, but just want to highlight that we've got lots of evidence to suggest that this model of healthcare delivery does indeed work. The group Health of Washington has been able to successfully reduce emergency care, see less staff burnout, certainly improvements in patient medication and patient experiences, lots of references cited for you there. Looking at the Geisinger Health System, which you have no doubt heard a lot about, they've been tracking their patient-centered medical home initiative over time and have seen tremendous results, many of which are listed in this slide. The Veterans Administration embracing the patient-centered medical home over the past few years, and seeing reductions in emergency room visits, inpatient hospitalizations, etc. Health Partners Medical Group in Minnesota, seeing many of the same sorts of results, looking at the importance of integrating behavioral health. Sorry, you can't see the Palmetto primary care physicians, but they're in South Carolina. They've recently embraced a patient-centered medical home together with the Blue Cross Blue Shield Association, and are seeing tremendous opportunities and very fast results in terms of reducing inpatient hospital stays and emergency room department visits. Looking at Community Healthcare of North Carolina, another program that has been operating for some time, seeing lots of results there. Recent results coming out of Blue Cross Blue Shield of New Jersey with Horizon Blue Cross Blue Shield, looking at some patient outcomes in particular, and seeing improved diabetes control, better screening for breast and cervical cancer, but again, reductions in ER and inpatient hospital readmissions. And then a very busy slide, which we'll be fixing, that looks to the many successes that we're now beginning to see in Medicaid all across the country. And I really would credit those Medicaid programs that have embraced this model, working with local commercial plans, in some cases working with their local Blues programs, being able to demonstrate providing higher quality care at lower cost. Of course, it takes lots of work and collaboration to make that happen. And I want to also spell out how the commercial plans have really stepped up to the plate and are embracing this all across the country. We see a WellPoint announcement back in January, embracing the patient-centered medical home model and rolling this out nationwide. Aetna also rolling this out in a number of states. I mentioned Blue Cross Blue Shield of New Jersey and certainly Florida and many other states. And so the WHO really just needs to focus for a minute back to the patient, recognizing that the patient is a consumer, and their voice is not only what drives the marketplace, but it also what drives public policy making. And so thinking about the importance of educating that consumer, who is also the same person electing officials in both their states, as certainly in Congress and in our presidential office, making certain that they understand, that is, those patients, why this model is important, how it can impact their own individual health, but the health of their communities, the health of their workplace, and how ultimately it can impact overall healthcare costs as a country, and really wanting to sing the praises of David Berwick for a moment, who reminds us again and again and again, when this is right for patients, it's right for everyone. The Patient-Centered Primary Care Collaborative, then, just reviewing this for a minute, is the organization for which I work. And this particular organization, beginning in 2006, is really trying to as Fred pointed out, advance an effective and efficient healthcare system built on the strong foundation of primary care. We've got about 1,000 members today. Many folks credit the big leap in membership to our founder, Paul Grundy, whose picture you see here, and those joint principles that Fred had mentioned earlier, those joint principles being adopted by the 4 primary care associations listed here. Finally, I would point you to some of the points that I've been making earlier, and that is we've been campaigning for a patient-centered medical home. We've been seeing success all across the country, but there's a real opportunity now. The momentum is with us, and we are at a tipping point to help those families who want better care, as you see in the lower right-hand corner, the insurance world that have really, without this private sector and public sector collaboration, we won't be successful in the long term. We believe the role of the collaborative is to to lead from the front, to challenge the status quo fee-for-service system, to provide you with information that we think is going to be critically important in the private sector, in the public sector, and then providing those networking opportunities. We hope you support our goals and bother taking a look at our website and getting engaged if this is also consistent with where your organization is heading. And with that, I turn this back to Fred, who I think will introduce Mina Harkins.
Marcy, that was a terrific overview presentation focusing on the 5 Ws. Really wonderful. Thank you. Now we're going to hear from the National Committee for Quality Assurance, and we have with us today Mina Harkins. Mina has been with the National Committee of Quality Assurance, the NCQA as it's known in the industry, and is the Assistant Vice President of Recognition Programs. She's based in Washington with NCQA, and this is the position that is responsible for the operation of all recognition programs and the new ACO accreditation program that NCQA is utilizing. The recognition programs are focused on quality management of chronic conditions such as diabetes and ischemic vascular disease, and the systems and processes utilized in clinical practice, including patient-centered medical homes. Before joining NCQA, Ms. Harkins served as the Accreditation Division Manager with COLA, a CMS deemed Physician Office Laboratory Accrediting Agency. She was the Director of Anatomic Pathology Operations at Quest Diagnostics and has held a number of positions at multi-specialty group practices, including a Manager of Laboratory Services and a Supervisor of Surgery, Urology, and Plastic Surgery. So you can see she has a ton of experience and she holds an MBA as well as a BA in Medical Technology. So we're very thrilled to have Mina, who will talk to us about what the NCQA is up to. Mina?
Well, thank you very much, Fred. Glad to be with you all this afternoon. As you noted, NCQA is very engaged in the patient-centered medical home, but we are more broadly engaged in the development of performance measurements and standards for care. We originally operated primarily in health plans and developed the HEDIS measures that are widely used across the country. But our basic vision is to transform healthcare quality. Our vision is to do that through measurement, transparency, and accountability. So we really felt that we were well positioned to move into assessments at the clinician and practice level, and have spent much of the last 4 or 5 years in developing standards for the patient-centered medical home. And we really took our cues from the endorsed principles of the patient-centered medical home by those primary care organizations that Marcy mentioned. And, you know, we try to bring all of the stakeholders to the table. Speaking to with the National Priorities Partnership, you know, we agree that you must first have a strategy for quality and believe that the U.S. can have a better healthcare system, and we need to focus on, you know, what are the challenges that are facing us, improving safety and making care available across vulnerable populations and across all payers, removing waste out of our system, looking at these various priorities that we can engage in to proceed on this task of quality improvement. We're going to be pointing to some of these key elements as we talk about care transformation and how we try to focus the standards that we've developed for assessing a practice's capabilities and performance as a patient-centered medical home. These are the elements that go into our determination of the practice's performance. So the different priorities that are shown here are going to show up over and over again in order to help us move from the right side of this diagram to the left, where we are going to focus on having the right care and advice at the right time. Doing that will both reduce cost and reduce risk and help improve the population health and the health of individuals, both of which are necessary to have within a healthcare system that is performing in a way that is going to lead to better health, better patient experience, and reduced costs, the triple aim that we've all been focused on, whether CMS continues to call it that or not. Some of the opportunities that you can see, this is also from David Nace. We are faced with a lot of patients in many areas of the country receiving a lot of their care in the emergency because they don't have access to care in any other way. We have patients that are being readmitted to hospitals because they didn't have a good transition of care. They don't have good access to advice to proceed with, their medication reconciliation. We have patients who don't see the same physician time after time, losing that continuity of care that contributes to care coordination. We have a lot of opportunity in our patients with chronic diseases, and we do have some models that feel it's important to just focus on those patients with chronic diseases that, that's where a lot of money is being spent. But that's very short-sighted because it's leaving out the whole premise that patients don't just appear with chronic diseases, they develop chronic diseases. And there is a pre-disease state in which we need to be actively outreaching to patients to see that they're getting their preventive care and that we find early markers for diagnosing these diseases based on evidence and allowing us to help these patients have a better lifestyle and engage them in maintaining their health. So these are all the opportunities that we had to improve. And as Marcy mentioned, some of these same studies are noted on this slide. We are making improvements. This medical home model, we are continuing to see the evaluations show savings all across the country. And we are really elated to see the number of medical home initiatives that are going on. They are supported by health plans, quality improvement initiatives, grants, state payers, federal, the CMS, and Medicare program. So we have a lot of activity around the medical home model, and the more that we see, the more positive results that we are seeing. Having had the opportunity since 2008 to be assessing patient-centered medical homes and being involved in some of the demonstration projects, we've noted that the very successful medical home pilots have had some key features. And I must say there have been some not-so-successful medical home pilots that really haven't looked perhaps at all of those priorities and the patient-centeredness and the patient population. And so the things that we have found lead to successfully transforming a practice and delivering this kind of care needs to make good use of all of the non-physician members of the care team, specifically in their role as care coordinators, expanding access to their healthcare team, or to any clinical advice, especially when it can be delivered in conjunction with access to the patient's clinical history and medical record information. Thereby, these data-driven analytical tools, such as the electronic medical record, are really contributing to the efficiency. We do get some pushback about perhaps the cost of, spending more time with the patients and doing the outreach for population management, but it is these installations of electronic health records and other analytical tools and services that allow that care team to function in a more effective and efficient manner so that eventually we will become more efficient utilizing the resources that we already have within these various practices. And then, of course, incentives. Incentives are driving the adoption of the medical home. I noted just nod to the CLE for New York State, but I must mention that New York State is our, I'd say, largest active group in the PQA, Patient-Centered Medical Home Program. There have been at least 5 or more different demonstrations and initiatives that include the whole state Medicaid operation that is paying a higher, in the managed care plans, they're paying a higher per member per month fee for the practice's recognition as a patient-centered medical home. And on the fee-for-service side, they're paying increased reimbursement based on the level of recognition that those practitioners and practices achieve. We've also seen that it is the access to care outside of regular business hours that is really reducing costs. We did some focus groups on practices that had achieved, of patients in practices that had achieved patient-centered medical home recognition and some that had not. And even though the patients, in some cases, didn't know they were in a patient-centered medical home or didn't know what that term meant, it's still, as Marcy mentioned, it's not well accepted as intuitively telling patients and others what that model of care is. But the patients knew that something was different, and the patients clearly were learning as well, and we need to engage them as patients and consumers to engage and become involved in this model of care, which these patients said they didn't even know that they could call their physician's office on Saturday evening and find out what to do with the child who was ill or their problem with their medication or, should they go to the emergency room. So we realized that we needed to advance the requirements that we were looking at for the patient-centered medical home so that we focus more on meeting the patient's needs for avenues of communication and access. So we've also found in Pennsylvania, previous governor, had a great initiative going where each of the practices in various regions of the state were engaged in becoming patient-centered medical homes in a chronic care initiative. But they also found a great benefit within the practice itself that it improved not only the patients but the providers and the care team's experience in the quality of care. So the visits to the primary care practice, it turns out, did not necessarily decrease. So we aren't maybe saving activity at the practice level, but we are saving dollars in the more expensive care environments. Now, NCQA, as I said, is an assessment organization, and so we do have a program that evaluates a practice as a patient-centered medical home. It does have a great penetration so far as different plans for recognizing such a model of care. We have over 4,000 primary care practice sites recognized with over 20,000 clinicians. If you extrapolate that to a number of patients, it's hundreds of thousands of patients. We have a lot of support from states, health plans, and other groups that, can go to a standardized set of of requirements and know that, implementing this will allow them to have a benchmarked set of requirements in order to designate whether a practice has achieved this model of care. So we brought in the stakeholders to all address how to develop these standards that we use, and we have designed them in a way that recognizes there are all different kinds of primary care practices. There are, large clinics, there are outpatient clinics, there are residency clinics. There are still the solo practice in many areas that, a family member might be doing the reception and the billing, and other members of the close community make a very small care team. But we knew it was important to give a roadmap for what these requirements and these quality goals and how to develop this systematic approach to delivering preventive and chronic care. And so we've seen great success for practices of all sizes, especially if they engage in adopting an electronic medical record. But we can help practices achieve recognition at admittedly a level 1 rather than a level 3 medical home, but without a medical record, they can achieve a level 1 recognition. It does have this baseline of requirements that we know will improve quality and reduce costs, and so it has a wide appeal to a lot of different segments. One of the segments that is really going to lead a large number of centers to become recognized, HRSA in the Bureau of Primary Care does have funding available for community health centers to become recognized and to gain some technical assistance in making any transformations and adoption of health information technology. CMS also has an advanced primary care demonstration project. Both of these programs, NCQA is the either contractor or subcontractor to help deliver these assessments and help in the technical assistance about what is needed in order to become a patient-centered medical home. And the military health system, including the Army, Air Force, and Navy, have engaged us as well to assess their military treatment facilities with the commitment that our armed forces should receive the same quality of care as. So these are all leading a great drive for patient-centered care. So, where did these standards come from? Everything that has been developed out there as far as the theoretical frameworks for quality care, safe care, well-coordinated care, can kind of be put in some of these buckets you see on this slide. The chronic care model, championed by Ed Wagner, provided a lot of focus for the standards that are looking at decision support, a great advocate for patient self-management, how we needed to redesign the system, bringing in the community. Not everything has to be reinvented over and over again in each primary care practice. And this is one of the areas where North Carolina has been extremely successful in let's establish some resources in the community and then, connect all of the primary care practices to those resources. So there are many ways to go about this, and we're learning every day from the projects around the country that are successfully putting these things in place. And each one of these gives us greater learning to how these can be implemented in the most efficient way. And so, it really becomes a learning experience. Patient-centered care as a strategic priority allows us to, look at that culturally appropriate delivery of care, providing patients with information and education, including the family where appropriate, but also respecting the patient's values so that we can deliver care in a culturally competent manner and reduce the disparities in care by making sure that all patients in the patient population have equal access to their care. The medical home piece of this, although it's an unfortunate term that gets misunderstood, it's just to say that, this is where everything should come back to. It's not a gatekeeper. It's not controlling the patient's health or care, but it is coordinating the patient's care, and it is doing it in a directed fashion so that each member of the care team helps coordinate that patient's care almost as a roles within a care family. So the development of our current set of standards, this is our second version. We had a version out in 2008, which we have just retired and are now evaluating practices with our 2011 set of standards. And some of the things that we learned from our first 3-4 years in doing these evaluations, it's just been really rewarding to see every type of primary care practice show how they've taken, their own care environment and their own patient populations and implemented these standards, because we are not particularly prescriptive. We might say that, you need to provide same-day access to care, but we don't tell every practice exactly how they have to do that. Now, that provides some practices with a little consternation. They occasionally like to have things very well laid out. This is the plan I'm supposed to follow. But, we do help practices. We try to engage them in educational opportunities where they can talk to each other and, develop in each care environment, what will patient-centeredness look like to them? What are the language and cultural needs within their patient community? We've taken a lot of time in looking at how behaviors health and bringing aspects of health to our standards, looking at those cases where patients have both chronic conditions and mental health or substance. We also enhanced the applicability of the program to pediatric practice, although it was the American Academy of Pediatrics that first developed the concept. They did feel our first set of standards focused a bit too much on adult care, and so we broadened many of the acceptable approaches that would allow for a lot of the preventive care that takes place in the pediatric practice, but also on the patients with special needs and, the young asthma patients and those diseases that are growing, maybe not a disease, but a condition such as pediatric obesity that's increasing across the country. So the pediatric practice has the opportunity to show how they have implemented some of the requirements with the kinds of conditions that are seen in the pediatric practice. If you are familiar with the meaningful use requirements that were produced by the Office of the National Coordinator under CMS for incentivizing practices for the adoption of electronic medical record systems, NCQA was careful to assure that the requirements that we had within our program that addressed some of the same systems and functionality, that we would use the same requirements and the same thresholds, so that we weren't asking practices to do two similar but slightly different things. We were able to pull in all of the meaningful use requirements, and then where we felt important, we added to those so that we could address, what we felt was meaningful for the patient-centered medical home, but also addressing the meaningful use of health information technology. We'll talk a little bit more later about trying to improve coordination of care with various specialties, and our patient experience survey and our activity with the Agency for Healthcare Research and Quality for the patient-centered medical home model of the CAPS patient experience surveys, and we'll talk about that more in a moment. Again, we are focused on performance measurement and on cost savings so that we hit all of those areas of the triple aim. These are some of the key components of our 2011 standards. We're going to look at access. We have a number of them that are looking at extended hours and access to care, whether the practice is open or not, getting clinical advice, coordinating the care and the flow of information, what the care team looks like, getting everyone to practice at the highest level of their particular profession, helping patients understand that role of the medical home, and so we've introduced, the need for a discussion and materials with the patients that will allow them to more fully participate in the medical home, but also to see how it will better meet their needs. Looking at the implementation of evidence-based guidelines in care management, using them in both the pre-visit, the particular episode of care, and the post-visit, engaging the patients in their self-care management. I noted before bringing in more community resources, so this is a focus of one of our elements within the program. Identifying and addressing population needs. For some small practices, this is something that they really didn't feel was in their area of care, that, maybe the health plan did that or another organization. But that once they have the ability to identify groups of patients and the needs of various guidelines, that they can have a big impact on the quality of care and on patient outcomes by reaching out to them and seeing that they can improve the measurements in this patient population and improve the preventive care and the compliance of patients with chronic conditions to meet their treatment goals. And then another area that's new to some of the private practices was the idea of doing their own performance measurement. We got involved early on with our diabetes recognition program and found there were a lot of physicians that said, of course I'm following the ADA guidelines and the NCQA measures, but when they actually had to do a chart review and see over a sample of patients that they had to choose according to, a random guideline that we would prescribe for them, they could see that, maybe they weren't as consistent with their implementation or with their documentation. So engaging them in quality improvement was possible now that they had some measures in which to look at over time. As I mentioned, we have engaged in a new survey that's available. This can be done with or without NCQA's Patient-Centered Medical Home Program. We do also have certified organizations that can field the survey for practices. And over time, we hope that this will allow us to get some benchmarks and some standardized measures for patient experience. and the practice does get additional credit and a distinction if they do use the CAHPS Patient-Centered Medical Home Survey as part of their activities in the patient-centered medical home area. This slide just shows some of the alignment with meaningful use. There is, of course, some focus on those areas that will improve safety and reduce costs and duplication. Again, patient registries and tracking that will allow population management, capabilities to exchange information, and then, of course, performance reporting because clinical quality measures are also part of the meaningful use requirements. This is just an overview of NCQA standards. Our standards and guidelines document is available without charge through NCQA, so that if you want more detail on what these requirements are or how the program or how a practice engages in the program, that is readily available. As I noted, we have set it up so that practices have different levels that they can qualify for. It also allows that a practice can begin in the program and then move up to a higher level over time as they increase their capabilities. So we have what's called must-pass elements that are listed here. Within each of our 6 standard areas, there is a must-pass element that we felt was necessary to kind of standardize. We didn't want to call a practice a patient-centered medical home without having at least these foundational concepts and capabilities in place in their practice. But it does allow a practice to go through a process or an evolution and build on their medical home capabilities over time. So having a set of standards that a plan or a practice can implement gives them, a kind of a project management plan and a structure on which to focus their efforts to evolve and understand that it's been kind of proofed out in the field. It helps the whole care team within the practice develop better interactions and better communications. I noted some issues before about where we're fairly broad or flexible in our description, but it's to allow a larger spectrum of practices to become engaged in the program. Some of the things that different practices have to address in order to be successful at patient-centered care. While we get asked, can we do it without health information technology, we're really strong proponents that these systems facilitate patient-centered care. They absolutely help patients from falling through the cracks. It helps focus on those segments of the population that might need, more outreach, more hand-holding, more intensive efforts to get them to engage in their self-management support. So the whole effort requires usually a champion. We do recognize practices, by the way, that are nurse practitioner-led as well as physician-led. It is really those that are committed to the model and will be a strong leader to the team that are most successful. We are seeing more improvements to address some of these barriers for training. Having these other facilities and specialists in other groups or centers coordinating care, bringing this focus out about the lack of coordination and the need for care transformation is making more facilities and specialties aware of the need to coordinate with the primary care practice, and that it will address a broad spectrum of problems that we're seeing in the current model of care. Of course, there is the lack of reimbursement and resources, so the incentives are extremely important, but we have seen those payers and plans that have engaged and supported practices in going through this program or this type of transformation to the patient-centered medical home have definitely return on their investment. But we have to look a bit beyond the primary care and that piece about coordination and achieving coordination really requires everybody in the clinical neighborhood to start paying attention and cooperating in that effective care coordination. Elliot Fisher made this comment that we really believe in, that full access to all the information is necessary at multiple sites. And of course we're concerned about personal health information and privacy, but we've got to have infrastructure and changes of information that allow the clinicians to coordinate and provide patient information where it's appropriate. It is only that is going to eliminate duplications in care and the costs that involves in. So we've got to find incentives for everyone to share information and improve coordination so that patients aren't bouncing from one provider to another. A couple of resources, as we've been also engaged now in developing a program to recognize specialty care practices that coordinate with patient-centered medical homes. And in our research, we've found some interesting statistics about the challenges of the primary care practice, the number of other physicians that they might have to touch base with in a typical period of time. Looking specifically at the Medicare population, the number of different physicians that a patient might see, and a real need for things like medication reconciliation. Who's going to take responsibility for that if the patient's seeing several different physicians? Then among the elderly, the number of referrals that are made, obviously the referral care is an important aspect of providing patient with and meeting their needs for treatment, but we also need to recognize that presents a challenge to the care coordination. So we do need to find ways to improve this interaction, and it also is evident that we don't have enough primary care providers in many areas of the country, and you know the ability to attract young physicians into this does need to be supported by improvements in reimbursement. And I'm happy to say that there are a number of grants and initiatives that are involving residency programs that are going to help the physicians coming out of our medical schools to understand the importance of this model of care, and hopefully, you know, lighting a fire under the becoming a primary care physician. So the vision we may have for patient-centered care in the future, and Marcy showed a little of a comparison from where we were to where we need to go, and I think that as we can become more sophisticated on our exchange of information while protecting the patient's privacy, but engage that patient in care. In some cases, we've seen implemented information exchanges that certainly utilize the patient's interest in having a personal health record and using an interactive website that they can access even when they are seeing other providers. So our pathway to delivering to reforming our delivery system is going to be to continue on the road to the triple aim. We are also engaged in looking at the requirements that should be in an accountable care organization. We have built around our patient-centered medical home as far as our standards and concepts for an accountable care organization, so that we have that larger neighborhood that allows us to put it all under one organization that allows the patient's care to be coordinated amongst all those facilities. So I'll leave it there and turn it back over to Fred.
Anna, thank you very much. NCQA's recognition programs really provide a badge of quality based on standard criteria that really are going to help advance medical homes, have helped advance them, and will in the future. For those of you who are reporting to New York State on your CLE, I'm providing you at this point with the first New York code. So mark this down. It is NJHRW. That's NJHRW. We now have the opportunity to hear from Dr. Leonard Fromer. He has spoken with us before, presented with us before, and does a great job. He is the Executive Medical Director of the Group Practice Forum in Los Angeles. He also is an Assistant Clinical Professor in the Department of Family Medicine at UCLA. Dr. Fromer is a member of the board of TransferMed, LLC, and acts as a consultant to TransferMed in the area of clinical integration, Center of Excellence, quality improvement in the chronic diseases, coupled with successful practice transformation to the patient-centered medical home and accountable care organization. As Executive Medical Director of the Group Practice Forum, Dr. Fromer leads a team engaged in national projects with group practices that deliver education, tools, and services to achieve success in their clinical integration efforts. So we'll turn it over now to Dr. Fromer.
Well, thank you, Fred. Appreciate it. Good afternoon, everybody. It's a pleasure to be with you. I want to start by thanking Foley and Lardner for enabling this transfer of information to happen. And I most of all want to thank everybody, all of you who are listening, for giving us time on your busy day to participate in this process and hopefully move the needle forward in improving patient care in the system we work in. What I'm going to do is a little different than what you're used to. I'm going to actually speak from my heart and soul as a family doctor and really speak in the first-person sense as we go through the perspective of everything that we've been talking about and more to come from all the stakeholder positions. What does it feel like, and what do we do in reaction as primary care physicians in our practices to these principles? What you see here, Marcy has covered already and shown. The red line is the United States. We spend 2 to 1, the nearest country, to what we spend per person on health care. What do we get for that? Well, if you look to the left there, primary care sees ourselves as always having provided and still providing medical home services for patients. The typical reaction from my colleagues around the country, if we wear our primary care hat, is, I've always done this. What's new about a medical home? Well, what's new about it is the Saturday Evening Post, Marcus Welby, who took care of one patient a week and always cured them, couldn't push a few buttons and say, here's how I'm doing with all my diabetics. Here's how their experience of care is. Here's their outcomes of care. How do I continuously improve that? What am I doing with my care teams to deliver patient-centered, population and disease-based, value-based results? And I'm going to posit to everyone that what we want to be doing in primary care and what we're engaged in trying to figure out how to do in response to all of this is, what is my patient's journey through their care? How do we enhance that? How do we look at all of this from what the patients are going through and make the experience in that process of care better? How do we re-engineer that workflow? And what we do is we start with looking at how do we define success if we're going to be a high-functioning, advanced primary care practice, which is one way to translate what is a patient-centered medical home. Well, in our view, in our perspective, it tends to be that we define it as an advanced practice of primary care medicine. And this is what success looks like. We have everything we need at our fingertips to take care of the patient using technology. We have imaging, we have ancillary laboratory data, we have data from all the specialists we work with, from all of the other pieces of the healthcare equation and universe in front of us on our dashboard of information. All the members of our care team, which includes our patient, coordinate the care, and we do that through good to excellent communication. That's a big challenge, as you're going to see in a few minutes, and I go over. It is a very big paradigm shift for us in our small business of primary care medicine. No matter what size group we're in, we're still relatively a small business. How do we go from one communication channel between those of us wearing the white coat and the patient to a care team process in which we have an enormously increased number of potential channels of communication? Managing it, making it effective, and making it flow in two directions is easier said than done. We have to utilize technology to its fullest to engage the patient, and we actually have feedback and information on which specialists we send the patient to for care, which bricks and mortar institutions they go to for care, what happens outside our office in the community, and we can take action on that feedback and knowledge and metric scoring on who's the best and what do we do about where we then send the patient in the future. The medical village concept has been covered by previous speakers very well. I will just kind of lay out these bullet points here about what it really means. It's collaborative team-based care outside of the four walls of our practice and our group. It's coordinating it actively across transitions of care. And that's not just inside and out of the hospital. That now, as we know every day in primary care, is much more about the transition between my office and the pharmacy. Do I manage that with my team well to improve adherence to taking medications, access to the medications in the first place, pickup of the medications in the first place, and then taking it right? It is about sharing responsibilities across all of the stakeholders, and particularly moving the patient from a passive position of, I'm broken, doctor, you have to fix me, to I need your help to manage myself, particularly around chronic conditions. I need the help of the care team to do that. How do we motivate the patients? How do we light a fire under them, as well as transfer knowledge to them? It is about using technology. It is about sharing this vision, and it is about education at the appropriate level of health literacy and improving that health literacy level. So we do it through this medical home concept, and it starts with, and what we have been hearing now going on 8 years since TransferMed started, this vision in primary care across pediatrics, internal medicine, family medicine, and osteopathy, the four original signatories to the principles. It is about this comprehensive, long-term relationship with a personal physician-directed care team across the entire body and continuum of problems, wellness and illness. It is about much more that we need to manage people and keep them well and help them deal with their chronic illness if they do have chronic illness than about rescuing people and putting out fires all day long. The problem we face is that we come out of a pipeline of training, and I think Marcy pointed to this very accurately and astutely. If we are training people in academic centers that primarily consists of inpatient experience in a rescue situation, then that's what we're going to learn and that's what we're going to do when we get out and practice. We need to reach down into the pipeline of training, and then it's going to take time for those folks in that training process across the continuum of care and primary care, including PAs and nurse practitioners, including nursing, to say, well, this has got to be about fundamentally regular planned care, looking forward, not looking backwards, keeping people well, and not just being built to rescue them. So the elements around this core of comprehensive primary care, I'm going to go through these, and you'll notice that they correlate with what Nina presented as the elements around which we do recognition on the medical home from NCQA. I'm going to lay it across, well, what does this really mean in the reality of the chaos of modern managed care practice in a primary care setting every day? Let's start with access. We're being told we need to provide advanced access, extended hours, access on the phone, access in person, access between live visits. Well, the practices that struggle to do this recognize that if we are fundamentally organizing our small business around the needs of our physician and our care team and not around the needs of the patient, we've got a long way to go from giving the patient what they really, from what we do now to giving the patient what they really need and want every day, and that's advanced access. And here's a list of the ways we're trying to do it, but I can share this with everybody. The thousands of practices who have now in primary care embraced the science of advanced access, who have worked down years and years of their backlog of what they do and organizing around running faster on the hamster wheel every day to rescue sick people, put out a lot of fires, and move towards forward-looking, pre-visit planning, doing today's work today every day, and all the elements of advanced access. Those practices have recognized and seen a tremendous improvement in achieving their triple aim, which is a little different than Don Berwick's triple aim. And the triple aim in primary care practice, as an analogy, the three things are: we get better results in patients and give them a better experience of care when they seek and get care. Number two, we have a better experience in the care process among those of us on the care teams in our practices. And third, we have alignment with financial payment methodologies and contracts that reward the elements of doing all of this. That's the triple aim for primary care. The second piece and principle here is this comprehensive basket of services that we want to get back to providing. And in the minds and viewpoint of those of us in primary care, what my colleagues and I are struggling with is, over the years, what we've been trained to do has eroded. It's been eroded by regulation. It's been eroded by market forces. It's been eroded most of all by what people like leadership at the Center for the Health Professions, Ed O'Neill, has said very astutely. The answer of primary care over the years since managed care started to dramatically change the landscape, that primary care answer has been, no problem. I'll succeed with this new set of realities by just running faster on the hamster wheel every day. I'll just do it quicker. And, of course, there's no end game there. That doesn't work. We have to re-engineer what we do, and part of that is those things we cut out from the comprehensive basket of services have to be brought back in, and we have to lean on our team to be able to deliver all of that. Actively care coordinating and managing our populations across these transitions of care. The list of things you see here, that's easy to say. It's very hard to go from reactive to proactive. And proactive care coordination and care management, we need resources to do that, sometimes capital resources. Well, what we're facing every day in primary care is, do we have access to capital without selling the ownership of our practice and signing partnership arrangements to join groups and institutions larger and larger that take away from us the ability to decide internally how to impact these principles. So it's a struggle to match those two, the intersection of clinical excellence and the business of healthcare is very frequently in primary care a collision. It's not a nice, pretty intersection. And How do we navigate that to avoid those collisions and make it work for the benefit of our patients more than any? That's what care management, care coordination, these principles are all about. How do we promote this every day and live this every day rather than react to this every day? Get out in front of it and live it every day, and the culture of the practice is the challenge. When we delve into care coordination, one of the elements that Ed Wagner really pointed out well, and you'll see in a minute here in a visual, is the patient lives in the community outside of the health system, not with us. And if they do that, and they do that even when they have multiple chronic conditions, 90+% of their time, how do we make an impact on that and build what we do around that so that we can coordinate the care and the reality of the lives our patients learn, work, play, and go to school in? That is our challenge in primary care. And I personally can tell you, when I'm in front of 1,000 family doctors at a big meeting and I ask some of them, do you think it's your role and your responsibility to impact the health and wellness of the patient through activities you can undertake with your practice teams outside the four walls of your practice and the health system in the community they live in? Every hand goes up. But then when you ask them, are you actually doing things to impact that in the community with activities that you've structured and planned and been proactive about? One hand goes up, maybe two hands go up. We know we need to do it. We struggle to implement it. Where are the tools to do it? Where is the time to do it? A lot of us are really struggling in the care coordination area, even if we're given resources from health plans and we have embedded care coordinators paid for by the health plan. We are struggling with what we realize is important but not urgent, in spending time, effort, and activity in that sector of what we do every day so that we develop collaborative relationships, manage them well with all these pieces you see in front of us, and particularly actively manage those care transitions. The practice-based care team, leadership, we get back to that so often. Every single one of us has to lead our care teams through this massive paradigm-shifting change. How do we share that mission? How do we have people think of team rather than I? How do we have our medical assistant get at the end of the day and feel, I didn't just put people in a room, take vital signs, and write a chief complaint for the doctor to come in and take care of the patient, but rather, at the end of the day, look back, smile, and say, I was a vital member of a participant of the care team that achieved a great experience of care for my patients, for our patients, and a great outcome for them. That's our really big challenge on the care team, to move that needle of behavior towards that. How do we, most importantly, communicate among ourselves so that we get effective decision-making diagnostically and therapeutically? How are we in primary care going to focus on quality and safety all the time, every time, on every patient? How are we going to take science, the knowledge we need to get, let's say we have it, how do we take what we know about the guidelines around evidence-based decision-making in each disease state for each patient and put it into practice? That particular challenge around clinical integration is a huge challenge. And how do we do that? How do we address that gap between we know what the right answer is on the test question, but yet in front of the patient the right thing doesn't happen because of system issues? How do we build our practice, our group, our integrated system as we go inside out? How do we build it so that we assure that quality and safety drives everything, and we do take that knowledge and get the right decision happening? What are we doing with our information technology? Meaningful Use is a great set of guidelines and parameters around what we should do. But look at the first thing that's on everybody's list of what we should do meaningfully with our technology. It happens to be e-prescribing. It's in 100% of everyone's list on what our challenge and solution is to moving the needle forward on HIT. But here's a little statistic that's scary. Those practices that embrace e-prescribing and do it actually have a lower percentage of their patients fill a prescription than when it's on a written piece of paper in the old way. Now, that alone is scary to think about, that if we move forward with technology and that happens, that less people pick up the prescription we give them because of that, what went wrong is not the deployment of technology. What went wrong is how do we use it meaningfully in the care pathway, the journey of care of the patient. And the solution to that problem, proven by evidence and studies on outcomes, is this comes from the pharmacy benefit management data around the country, and then applying what to do to fix the pickup rate dropping when it's e-prescribed. The answer is you can't drop e-prescribing into a broken care process that's fragmented, not team-based, and passive and reactive. If the day after that e-prescribing event, someone on the care team calls the patient and simply goes through a 30-second script, and it's never the physician who does this, it's someone else in the care team in the practice, and it could be done in a solo, small, 2-employee practice even. But someone has a script to follow that quickly says, did you get the medicine? Do you have any questions about why you're taking it and what we discussed yesterday? Are you having side effects? Was there an access issue with your managed care plan? And you go through this quick script, the pickup rate doubles, way above what would happen on a piece of paper the old way. So it's not that you e-prescribe leading to the problem. It's how we use it and deploy it. And every one of these bullets here on HIT, that is true about how we deploy it, the tools needed to take that and make it happen well. Managing the practice, we are all in a small business in primary care. No matter how big our group network or even IDS is, it's essentially a small business compared to the Fortune 100 or 500 companies that employees who work there are coming to see us for care. How do we organize ourselves and compete in that world, which has a lot of analogy to Main Street America competing with Wall Street America, a lot of analogy to the mom-and-pop businesses on Main Street America competing with the big box, large corporation chain stores. There's a lot of analogy there to primary care and its place in the healthcare system and its place in our economy as a small business, and can we bring to bear the resources to practice this bullet point of issues that you see there. It's a challenge. So putting this together schematically, here's our medical home visually, the elements that each of us in primary care know we need to and want to have, and then we hang on that, the pieces that we just talked about and what really these boxes mean in the building blocks of the medical home, we start to see our challenge and our opportunity. And this is what we think about in primary care every day. How do we get this done? How do we get it done aligned with that triple aim at the end of the day of better patient results, better experience of care in those results? Secondly, better outcome of the care experience process for our staff and ourselves, taking care of the patient. And third, how do we align all that with a contract and financial payment methodologies that reward it? And you see illustrated here in the roof here the great outcomes. We always focused, and still do, and rightly so, on great outcomes for the patient. That's what we want in the medical home model, the advanced practice model. But we can't forget what's in great outcomes. Embedded in that is also great outcomes for the staff and ultimately the physicians, which leads to great outcomes in the healthcare process for the community we all, again, learn, live, work, play, and go to school in. The benefits of the team-based approach are right here. We know what they are. They all point towards that triple aim. They all are the right way to go. We know that. The challenge we have is how do we build that team and put these pieces together so that we can achieve what we know is in this pyramid of delivery of this team-based approach and reach that reality. Who was on the team was actually covered earlier. I just want to make a few points here. The perspective of my colleagues in primary care, we have a vision of the team that frequently stops at the walls of our offices. And it's a struggle to get beyond that. It's a struggle to think about how do we engage the pharmacist down the street in either a community setting or literally in an academic or a teaching setting who is on the team. How do we engage the specialists who we send patients to and understand that there's a way to know through metric scoring who is doing a better job in achieving the results we want with our patients to make better decisions about who our patients should be seeing, and so forth and so on. It is a challenge to do that. Ed Wagner gave us this vision of what we could be doing around the chronic care model. I've drawn it here in a way that emphasizes that concept of the community being so critically important. The sweet spot of where we interact with the community has to be proactive outreach by a practice team interacting with a patient who's not just informed, who's not just gotten a transfer of knowledge from us, but has a fire lit under them so that they are taking care of themselves with their caregiver, families, and friends with our assistance. All of it driven by clinical outcomes, quality, and safety, by the evidence to make better decisions scientifically through the evidence on diagnosis and treatment. We talked about communication. It gets incredibly complicated. We feel that every day in primary care when we start to build teams and we realize if we don't have the electronic platform to effectively put in front of everybody on the team at any point in time the same data on a dashboard of what we know to make better decisions, it would be like trying to drive a car from point A to point B without a dashboard telling us how fast we're going, what gear we're in, and what's happening with the elements of the motor in the car that we need to know that is operating safely and effectively. It's a challenge. It's hard. But when we start to look at it this way of the number of channels of communication that are there, with information from research that's been done, excellent research showing that when patients rate our care team's ability to communicate with them and their caregivers as good to excellent, then adherence and concordance rates on what they need to do in their behavior in the world they live in terms of lifestyle, and what they need to do in terms of medication and intervention, that adherence skyrockets. When they rate us as fair to good as communicators, it generally hovers only around 50%. So that's a gigantic issue. Part of the problem and challenge that we have is that we face chaos every day in our primary care practices, and this is adding to the chaos. This change is chaos. We all know there's only two kinds of people who like change: wet babies and consultants. The rest of us, particularly doctors, have struggled with change. We're afraid of it. We're defensive about it. We don't have time for it. But when we stop and think, the light at the end of the tunnel here is that chaos is normal, and if we just watch it happen, manage it by looking forward in time towards a new status quo where the point we're trying to get to has incorporated in it less chaos, the transformative process is then understandable, digestible, and it doesn't pretty much knock us out of the box in that pathway towards that new status quo. Focusing a little bit on something that was brought up before, the agreements we have between specialists and primary care. We've never in the past and in our training came out of a process where we formally had a set of metrics and agreements that aligned quality outcomes and quality experience of care for our patients with a payment methodology process and a report card process that helped us select who our patients who needed to see specialists were going to go to. That is part of this, and that's one particular example where we are working hard through a templating process to really develop a way for the practice primary care team to say, all right, if I have a patient going to this cardiologist, here are the things we want to flow back and forth in the information. Here are the access issues we need, and here's the evaluative process we're going to include so we know who's doing the best job and getting the best results to make future decisions about who we send people to. All of the things about technology that everyone has talked about are critically important. We need to live in the 21st century around technology. These are some of the elements around it, but I wanted to just put a word in about what primary care and my colleagues and what we are all struggling with, which is we can buy and install, and a lot of us are already working off electronic medical records. how they're used in the workflow process so it's not just electronic paper. That's our challenge. And most of us, unfortunately, are ending up in vendor situations where we end up with electronic paper, and that's not getting the disease management and practice management and population management done. So we need solutions that put together all of this in this new world of doing population and disease management care driven by the science so that we can attain that triple aim for the patients, the patient side of it, the great outcomes for the patients of great process of care, great disease state outcome, and an improvement in their lifestyle, their life status, so that the system works for them as much or more than it works for us. The payment methodologies that have been listed already, and I get back to here, make the point that there are everyday new ways to alternatively pay primary care for services provided outside of the fee-for-service only volume-based world. The struggle we are having, and we are asking the system to help us with, is how do we transition from a world of volume, that's all we've known, see a patient, measure how much we've done for them by coding it, submitting a CPT set of codes, getting paid for the amount of care we've done. How do we transition from that to value? What is our strategy to have feet in both worlds and continue to make that bottom line, continue to have a sustainable model? So these payment methodologies are great, but they can't replace, they have to add to and transition us from volume to value. Finally, I want to just finish quickly with, I've said clinical integration. I talked about addressing that gap in knowledge, and I talked about the care workflow process. Well, here it is. The patient journey is primarily about these elements you see here in getting the patient where they need to be in their chronic care process. Here's Ed Wagner's model again, drawn a little differently. The same pieces are there, but if we apply that across any chronic disease, the pillars at the bottom around these elements that we have to do well inform us on how we put together this timeline that has in those color-coded boxes all of the touch points by the care team members that we can lay out in any disease process, care process, of what has to be done by each person. Those white boxes above it are for each care team member when we start doing this process and teach it in our system, in our network, of what each stakeholder in that process, each person on the care team starts to think we can do differently tomorrow, today, and really start moving the needle to get the patient what they need and what they want. Lastly, I just want to say the perspective of primary care is that we're coming out of a world where the different stakeholders have been competitive and on the other side of the table, frequently, not just figuratively, but literally in negotiations. And getting past that into a team-based model where we are all trying to achieve the same thing and reward the same thing, which is delivery of value and better results for the patients, that is typically the biggest challenge we have. Making it all about value and not volume is where we are living every single day in primary care, and we are acutely aware of the fact that we know that we've got to step up to the plate and be leaders in this process of change for all the care team members and the system, and that is a challenge also. We have answers, we have progress, but it's slow, and the good news and success story is we have got people on the same page in the need to get this done. As we bring tools and resources and the how-to to them, they are responding well. My colleagues are responding well. Thousands of practices embracing the medical home solution to this as an advanced primary care solution and leading through this change. So I'm going to stop there, and I'm going to turn it back over to Fred and look forward to the question session.
Len, thank you very much. It's really great to hear the primary care practitioner's perspective on medical homes. Our next speaker is Dr. John Sprandio. He is the Chief of Medical Oncology and Hematology at Delaware County Memorial Hospital in Delaware County, Pennsylvania. He also serves as the director of the Delaware County Regional Cancer Center and is a member of the Fox Chase Network, director of the Medical Oncology QA program, and chairman of the Department of Medicine. Dr. Sprandio will bring us a specialist experience with the actual implementation of a medical home. And without further ado, I'll turn it over to Dr. Sprandio.
Well, thank you, Fred, and I'm very happy to participate in this event today. And I need to say that I've enjoyed the previous speaker's presentation. I just wanted to go over an agenda today. I wanted to talk a little bit about the rationale for specialty transformation to a patient-centered medical home, give you a little background on our practice, describe a little bit how this model is put together for an oncology practice, talk about the ACPs, the American College of Physicians, concept of a PCMH neighbor, and how to vertically integrate with primary care and other entities. And then talk a little bit about building a medical neighborhood. So I'll move pretty quickly, and I'll be happy to answer questions a little more specifically at the end. In the era of healthcare reform, as you know, everything is a major focus on value and demonstration of results. And value is really a measure of quality or patient satisfaction or some combination thereof, and cost. High reliability organizations or organizations that are prone to failure. Medical care is essentially a high reliability organization, and we need to do what every other industry in the country has done, which is incorporate high reliability principles into our daily routines. We need to prepare for value-based contracting, and this is contingent upon data transparency, accountability, and a rapid learning cycle. The cost portion of this is addressed by addressing failures of delivery, failures of coordination, and failures of overtreatment. In medical oncology and cancer care in general, these three failures are all too common in terms of how cancer care is executed and delivered. We started, just a few words about the practice, we started to re-engineer our process of care in 2003. We brought in some IT infrastructure. We developed some additional IT infrastructure because a lot of the EMRs out of the box do not really help us execute what we need to execute as physicians on a daily basis. And we focused a lot on streamlining and standardizing care, trying to minimize clinically irrelevant physician activity, maintain a patient-centric approach, and fix accountability of the patient-physician locus, and then address the deficits in communication and coordination, access, and engagement. We realized in 2009 that we actually met the criteria for the NCQA patient-centered medical home application, and we applied and we were awarded a level 3 recognition in April of 10. And the way this model works in our practice is that we really accept the responsibility for the coordination of all hematology and oncology services from the point of diagnosis and sometimes from the point of finding a radiographic abnormality through treatment and into survivorship or end-of-life phases of care. The idea here is to continue to engage the primary care team, having them well informed regarding the progress of the patient and addressing non-oncologic medical issues. So we don't practice internal medicine. We don't, in a classic sense, become a medical home. We're more in line with the ACP's definition of a medical home neighbor as a specialty practice. Just to quickly move through a couple of key points. As I said, we assume ownership of all cancer care needs. A lot of emphasis on the key things that you've seen in the previous presentations: education, engagement, compliance, self-management, the ready dissemination of information, and the coordination and management of high-risk populations. So the same principles for primary care in terms of the NCQA criteria have been applied to this model. We were kind of inspired by a lot of oncology guidelines and recommendations and critiques over the past 12 years, especially from the Institute of Medicine, with well-justified critiques of cancer care delivery dating back to 1999. And 4 key IOM reports are listed there. But also the National Comprehensive Cancer Network, ASCO, the American Society of Clinical Oncology, the American College of Surgeons as well have input into the model, or how we filled the specifics of the model. We ended up, we think, having a care coordination and delivery model that really facilitates physician accountability, encourages clinical integration with like-minded medical oncology groups, enhances coordination with primary care medical homes, and doing this while addressing patient needs and evidence-based care. As you saw, the model is very similar to primary care. It's a physician-led care team with the usual cast of cast members, including financial navigators. Cancer care is very expensive. Chemotherapy is expensive. Increasing co-pays for injectables and supportive medications as well as oral medications has required us to really have folks that can do pretty sophisticated financial navigation. We employ nurse practitioners, and we also have patient navigators whose job is to collect all pertinent data and schedule all appointments for testing and for any specialists that need to get involved in the patient's care. So we address all of that and coordinate the care for patients. Our patients never make any phone calls for any visits or any laboratory testing or radiographic imaging. So it's the same cast of characters really for every medical oncology practice, but the difference here is in following the NCQA template, we really developed a mutually reinforcing care team approach where, collaboration is throughout the care team. Adherence, for example, to evidence-based guidelines, chemotherapy treatment programs are really the responsibility for not just the physician but for all the caregivers involved in delivering that care. Enabling the ability for patients to have clinical calls through a telephone triage system and have unscheduled visits available. And as you've heard, it's a focus on patient compliance, proactive reporting of symptoms, and especially in cancer care, early notification of symptoms results in early treatment of complications and less comorbidity. The process of care has been standardized within our practice. We have clinical decision support tools at the point of care. We have patient portals, and we do have a telephone triage algorithms based on symptomatic calls. The things that we measure would be the things that you would expect to measure: adherence to treatment guidelines. We monitor performance status on a routine basis, which really directs not only our care but our strategies in terms of how to manage patients who are in a non-curative situation. And we measure our efforts at communication and coordination, documentation, turnaround time, and we follow a number of end-of-life care parameters for those patients who have metastatic disease. And we do utilize and develop a high-risk registry. The consumer assessment of healthcare providers and systems is a tool that we are beginning to use to really document the patient experience of care in this setting. But the key utilization parameters that we focus on have an impact on patient care, but also on cost. And those are as follows: chemotherapy guideline adherence, emergency room evaluations per chemo patient per year, hospital admissions per chemotherapy patient per year, length of stay. We monitor outpatient visit reductions with more complete and consistent approaches to patients and their symptoms we actually have documented a decrease in outpatient visits per chemo patient per year. We also measure the end-of-life care parameters, and we're starting to look at diagnostic and imaging and laboratory utilization. Here's some slides that show results. This is a pie chart of symptomatic phone calls from 2006 through 2010. The number of calls that we receive per year has increased significantly because it's a service that is patient-friendly, and they use it a lot. So patients are indoctrinated and engaged that if they have a symptom, they need to call early in the day, and they have the ability to be seen that day or the following day, depending on the acuity of the situation. So you can see cumulatively from 2006 through 10, about 75% of the symptom-related calls are managed at home, either through, usually through the direction of a trained oncology triage nurse who follows scripted algorithms for 30 different symptoms that we developed over the years. You see that about 5.5% of patients who call are seen that day. About 4.5% are seen the following day. Cumulatively, 5.8% since from 2006 through 10 were sent to the emergency room, and in 2011 that number was 4.2. So we've been able to successfully reduce the number of ER referrals through the telephone triage service. The real question is, what is the total number of ER visits per chemo patient per year? This is a more reliable indicator of practice activity, both during hours and off hours and on weekends. And we didn't really have a benchmark until April of 10, when the U.S. Oncology Milliman study was published, and they looked at 14 million commercially insured patients. There were no Medicare patients, there were no Medicaid patients. And they found that in this generally younger patient population with fewer comorbid conditions, there were approximately 2 emergency room visits per chemo patient per year. And in 2004, we were above that at 2.6. Again, our numbers are for our entire patient population, including Medicare and Medicaid patients. And we have been able to successfully reduce that number through a couple of avenues. Number one is the telephone triage service, directing patients to the office instead of the ER and having them admitted by a nervous ER doc who's not maybe familiar with caring for patients with their complications. And also we've been able to reduce the admissions by more proactively and more completely following symptom management and performance status as an outpatient. So we haven't plateaued. Our improvement in terms of the reduction of ER utilization from 2004, it's declined 68% per chemo patient per year. And from 2010 to 11, we declined another 10%. So we don't think it's plateaued yet. The other important parameter is the admissions per chemotherapy patient per year. And the U.S. Oncology Milliman average, again, for the younger patient population was 1 admission per chemo patient per year. And in 2007, our total patient population was a little bit above that. We continue to reduce the rate of admission per chemo patient per year through 2011. There was a 12% decline from 2010 to 11, and a cumulative decline from 2007 of 51%. We've also had, through a concerted effort, and using a variety of reporting mechanisms, we've also been able to address some key issues regarding end-of-life care. In 2009, our hospice average length of stay was 26 days. Nationally, that number is about 35 or 38. So we started to measure our performance and give individual physicians reports on their own performance. And basically, we were able to increase our average length of stay by 34% in the past 2 years. We also had a goal of fulfilling our patients' wishes regarding the place at time of death. 80% of our patients, 85%, would prefer to die at home. We were able to move that a bit from 2010 to 11, and we'll see if there's really a trend in that as we move forward. More importantly, we, in terms of ER visits and hospitalizations in the last 30 days of life, our rates we thought were very high in 2010. At 40% of our total practice admissions occurred in the last 30 days, 39%, and that almost 25% of our ER visits, the total ER visits for the practice occurred in the last 30 days. We're making a concerted effort to move this number down as well, and we think that there's significant movement that we can see with ongoing efforts. The end-of-life care parameters, we follow the Dartmouth criteria and the ASCO Quality Oncology Practice Initiative parameters, but we added a few things, such as documentation of advanced care plans and consistent measurement of performance status with each interaction. The savings are substantial when it comes to caring for oncology patients with this model. Basically, with the reductions in inpatient hospitalizations and ER evaluations, adherence to chemotherapy pathway programs, and improved end-of-life care, we think that we can save over 10 to perhaps 15% of the total cost of cancer care with this model in place. I must tell you that the data that I'm speaking of has come from one practice of 9 physicians in 4 practices in 4 locations, which really begs the question of, is this transferable and reproducible, and are there some unique features that make this an aberration? Well, we took that challenge, and we are in the process of transforming another similar size practice. And we term this horizontal integration, replicating the model. We've developed a way to do individual practice assessments and a detailed gap analysis based on the NCQA criteria and based on a few other criteria that we added specifically for oncology. And basically, we have successfully done this with a similar size practice, and we plan to potentially expand this to a clinically integrated network regionally in order to really verify the results that we've had on a larger scale. Regarding the vertical integration with primary care patient-centered medical homes, ACOs, and health system clinically integrated networks, we are on a mission to share data, develop interfaces, and really have transparent data regarding the initial consultation process, establishing the treating physicians, the oncologist, as the point of first triage when patients are being actively treated. Even if some of their symptoms may be related to comorbid conditions, any changes in chronic comorbid conditions are usually precipitated by a patient's therapy. So we've been successful in having our primary care physicians agree to direct their patients' symptomatic phone calls to us during the time of active treatment. A lot of focus on avoidable complications, intense focus on process of care and case management, a lot of attention in terms of transitions, not just from the acute care to the non-acute care setting, but also the transition from initial abnormality seen on an X-ray or CAT scan or the time of diagnosis to the specialist, to the oncologist. There's agreements around the survivorship phase of care, and we share data regarding high-risk populations, management of high-risk populations. We have established a formal coordination of care agreement with primary care practices that we are associated with or that we have referrals from. As was mentioned earlier, Pennsylvania is kind of a hotbed of primary care PCMH, and the coordination of care agreement was developed with 3 different large primary care groups that represent over 50 sites within our geographic coverage area. And just to go through that a little bit, the initial pre-consultation exchange, finding out about the key issues, having the ability to find out about key issues, and then triaging and timing the assessment. Establishing a care management agreement. Again, this is in line with the American College of Physicians, with agreements to manage with principal care for either a defined period, for example, in patients who are receiving a short course of adjuvant therapy over 4 to 6 months, or hematology-oncology evaluations, versus an extended period of care in patients who may present with or may develop metastatic disease. Regarding the initial consultation, there's agreement to carry out a standardized patient orientation and delineation of patient responsibilities as well as practice responsibilities, and then comprehensive care planning and execution of that plan. At the commencement of treatment, we agreed to monitor comorbid conditions and report to the primary care physician on a consistent basis, and really focus on avoidable complications. We've agreed to have consistent standardized communication, monitoring document turnaround time in terms of our progress notes to the physicians who are involved. We also, as I said, are responsible for scheduling all testing, whether it's radiographic or laboratory or specialist appointments. And based on the NCQA criteria, we also track that in terms of patient compliance. We also report all ER and hospital admissions to the primary care physicians, and we engage them in a standardized end-of-life care program. Many primary care physicians have long-established relationships of 20 years with our patients, and we may have a relationship with the patient and the family that might last 20 months. So engaging the primary care physicians in terms of discussions regarding end-of-life care is something that's worked out fairly well for the patients. In terms of survivorship care planning, we have an agreement to hand off the baton with a well-documented survivorship care plan to those primary care practices that have the IT infrastructure in order to execute on that plan in a consistent fashion. For those practices that don't want that responsibility or don't have the infrastructure, we continue to follow through survivorship. Again, it's in the best interest of patients, but we're ready to hand off the agreements for those primary care practices that have the IT capabilities to track the survivorship care plan results. We identify high-risk populations from our database to improve and better direct screening and genetic consultation when that is appropriate for our patients and their family members. Our goal in 2012 is to expand and verify this model and to refine and modify the model. We are engaging with the Centers for Medicare and Medicaid Innovation in the development of a clinically integrated network in southeastern Pennsylvania that will provide greater numbers of physicians and patients to see if this model can be replicated on a larger scale. We're having discussions with national and local payers, and we're also collaborating with the primary care PCMHs, payers, and health systems, a pioneer ACO in Pennsylvania, as well as national organizations, including the NCQA, ASCO, the Community Oncology Alliance, and the Association of Community Cancer Centers. We have developed a company that provides practice education assessments and toolkits, to help enable the development of this clinically integrated network in southeastern Pennsylvania. So I'm going to stop there. I moved quickly because I knew we were short on time, but I'd be happy to answer questions at the end.
John, thank you very much. That's very encouraging results and a very exciting model. Our last speaker, I need to give you the New York code for CLE. It is FOC9A. That is FOC9A. And now our last speaker, Marcia Guida-James, is the Director of Provider Engagement in Humana's National Network Organization. In this capacity, she has a leading role in provider engagement and payment reform activities, including being a key developer of Humana's Provider Rewards programming. She has more than 25 years experience in physician practice management from the consulting practice and health plan sides, and she remains deeply involved in the practice side in terms of clinical practice redesign, clinical decision support, payment innovation, and performance measures. We're really delighted to have the payer perspective, and I'm going to turn it over to Marcia.
Thank you. Hoping everybody can hear me. You see on this slide, what I'm going to do is go through very quickly from the payer perspective what our experience has been with the Patient-Centered Medical Home Initiative, and it's entirely positive. So on this slide, it's just a little bit about Humana. For those of you who are not familiar with us, we have a wide range of health insurance products, 12 or 25 years experience in the Medicare program. We're one of the top providers of Medicare Advantage benefits with approximately 1.9 million members. We've got 11.2 million medical members nationwide, and we have more than 300 medical centers and 240 worksite medical facilities. The next slide just talks just as an overview of what Humana has been doing in the medical home realm. We support our medical home arrangements in Florida, Ohio, Colorado, Illinois, Michigan, and so on. We have close to 100,000 commercial and Medicare members in medical homes in over 100 physician practices. We're also participating in the PCMH multi-payer collaboratives in both Ohio and Colorado. Colorado just ended back at the end of April. We're also really proud to support, and Marcy was on earlier and talked about the Patient-Centered Primary Care Collaborative. We're executive committee members on the PCPCC and have really supported it from the beginning. The next slide talks about, from the payer perspective, what does the payer bring to the table? We have heard from industry, we have heard from providers, but what do payers bring to the table? So this slide really talks about the collaboration between the payer and the provider to support the medical home. So just a couple things here. We bring to the table an attribution process to actually attribute members or patients to medical homes. We know in a non-gated environment, patients can go wherever they'd like to go, but we want to support the aspect that medical homes really truly engage those patients, and our attribution process reflects that aspect. We can also identify quality and utilization. We work with our providers to identify key metrics that they would like to follow, that we would like to follow in that particular population. We can do the cost analytics because the reminder is that payers really have close to a 360-degree view of where those patients have gone, and we can help the practices understand that. And then finally, we can provide infrastructure to support whatever clinical reengineering those practices would like to focus on. It could be disease management. Maybe the practices don't have disease management in place, for example, on a diabetic population, but the payer does. So we can bring that to the table as needed. Just a couple of slides to talk about what our results have been. In Atlanta, we had one of the first medical home pilots in the country, and we saw really positive clinical indicator results. As you can see here in this slide, for example, was an increase in the upper left-hand corner, an increase in with glycemic indexes or hemoglobin A1Cs less than 7. That's an indicator of how well that patient's being managed. They're diabetic. So the lower A1C level, the better. So, we saw an increase in folks who were managed with their diabetes. We also saw an increase in blood pressure management. Patients who were identified as having high blood pressure and the management of it. Same with cholesterol management. You see more patients being identified because they're getting those screenings. So we had a lot of positive experience with that pilot. Additionally, in Cincinnati, with another one of our pilots, here's a slide that talks about utilization. In the group in Cincinnati, their ER visits were reduced. ER visits per 1,000 were reduced, and mostly because those patients, there was greater engagement. Those patients were able to have the relationship with the physician that they would call and have greater access to that particular physician's group. I will add on here that we had an e-visit pilot also running concurrently with the same group so that we could see that by increasing access in that manner, that patients would have good experience with their physician and lower the ER visit rate. I only have a couple of minutes left. Touch on a high level, a couple of things that payers are able to do. We were also able to help provide support in terms of gap analysis, help practices get their NCQA certification. We were successful in helping practices in Florida, Cincinnati receive level 3 certification through NCQA. And we did that by going into the practice and helping them understand what the qualifications were to become certified, them through that process, helping them answer questions when they had questions, and providing information for those patients as they were information for those providers as they were filling out their NCQA applications. So I applaud NCQA there to make it easy for us to help the practices help themselves become certified. A couple other points, just want to touch on the fact that in terms of satisfaction, we found out early on that patients and we did surveys on the patients that were in these pilots. Patients answered questions positively in that the PCP helps me feel less confused by my health, provides educational information, I feel more controlled about my health. And on the other side, the providers felt satisfaction in that they felt more engaged with their patients. They felt like their lifestyles were positively influenced. So we had a lot of good come out of these pilots, and that's why we're continuing our support of medical home. One last, in the last minute or so, we're also supporting the transition of practices into meaningful use, and we're tying that into medical home program. Practices that qualify, Humana will help support their implementation of the EMR systems, and we also have relationships with some EMR systems. It's been in the news, Allscripts and eClinicalWorks, Athena, and next-gen, where we're able to lay down the pipes and working through being able to provide gaps in care to physicians who have these systems, that when a patient is in their office, they're able to understand, whether the patient needs a mammogram or colorectal cancer screening. We can help the physician understand that at the point of care. So we're developing those relationships right now. I think I'm going to go ahead and turn it over in the interest of time. I know we only have a couple minutes left. So thank you for allowing me the time to share with you this afternoon. Sorry this was so quick, but I'm sure we may have some questions.
Marcia, thank you very much.
Sure.
We do have a couple minutes left for questions. Are there any questions that we have, live questions?
Ladies and gentlemen on the phone lines, if you would like to ask a question at this time, you may do that by pressing star then 1.
Perhaps as we wait, there is one question that's been submitted. This is for Marcia. What kind of payment models has Humana utilized with medical homes?
That's a great question. We have utilized care coordination fees, where we're supporting, that practice transformation that takes place. That care coordination fee is on top of fee-for-service. In some of our medical home arrangements, we've shared savings arrangements, those practices that are more willing to take extra time and analyze what the total cost of care is, and it's all related to quality. So we've developed different types of models to kind of fit practices as they're doing their medical home transformation. So great question.
Okay. Thank you. We have another question for Dr. Fromer. How does the shortage of primary care physicians affect the future of the patient-centered medical home?
That is also a great question. The answer is the impact is how we organize to deliver care to a panel of patients. The average PCP in America takes care of about 2,200 patients, adults and children, if they're in primary family medicine. With the medical home model and having PAs and nurse practitioners on the care team and reworking the engineering of the workflow around team, we think that it is easily achievable with great care process and outcomes and great experience of care for both the patient and the care team to increase that to each physician chairing a care team, captaining a care team to take care of 5,000 patients. So that's one of the big ways to address the manpower, woman power shortage. Of course, we need to get more people into primary care in the pipeline, but that's going to take years to play out.
Mm-hmm. Thank you. I think we have time for one last question, and I have one for Mina. How many level 3 certifications, recognitions have you as NCQA issued?
We have, of the 4,200 practices we've recognized, 70% right now are level 3. In our previous standards, it was kind of disproportional if a practice kind of moved up into the higher levels, they kind of moved directly to level 3. We believe in the 2011 standards we will have probably a broader distribution of levels, and we did raise the number of points that were required for each level. So for the present time, I would say it's about 3,000 of those, 4,200.
Well, that is great. Well, that concludes our presentation today. I'd really like to thank our speakers. I found them very informative. I know a lot more about medical homes, and I think all of the speakers were just terrific. I would ask the audience to give us some feedback. The form is should appear on your screen, and if you take a minute just to fill it out, it can be very helpful to us as we plan future programs. And again, thank you all speakers and attendees. I appreciate very much your sitting through 2.5 hours, and I hope you come away as informed as I am. Thanks very much.
Thank you.
Ladies and gentlemen, thank you for your participation in today's conference. This concludes the program. You may now disconnect. Everyone have a wonderful day.